Junctional rhythms. Escape rhythms. Escape rhythms include escape beats, escape junctional rhythm, or simply junctional rhythm, escape ventricular rhythm, idioventricular rhythm, discussed with complete heart block. Escape beats. Escape beats arise when the sinus node fails to fire in time, and a latent supraventricular or ventricular focus fires an impulse, which can capture the heart. An escape beat comes later than the expected sinus beat, that is, it is preceded by a cycle length, CL, longer than the sinus CL. A premature beat, on the other hand, comes earlier than expected, that is, the preceding CL is shorter than the sinus CL. The QRS morphology of escape beats depends on their site of origin, and their conduction pathway. In premature beats, the preceding CL is shorter than the sinus CL. In escape beats the preceding CL is longer than the sinus CL. An escape rhythm results when the sinus fails to resume pacing, and the escape beats continue to pace the heart. Junctional rhythms. A junctional rhythm implies that the heart is depolarized by a junctional focus. The junctional focus may take over cardiac pacing in two situations. An escape junctional rhythm, in which the sinus node fails to fire, or its firing rate becomes slower than that of the junctional focus. Or, a premature junctional beat, which then continues to pace the ventricles, either because the sinus node is slower, or the junctional focus is faster. The normal inherent rate for AV junctional automatic activity is 40 to 60 beats per minute, and for those of pacemakers at the fascicular or ventricular level 20 to 40 beats per minute. Rates faster than the inherent rates, from either of these levels, are considered accelerated rhythms, up to 100 impulses per minute. Above 100 beats per minute, they take on the general definition of a tachycardia. These rhythms are thus defined as follows. Junctional rhythm rate is 40 to 60 per minute. Accelerated junctional rhythm rate is greater than 60 and up to 100 per minute. Junctional tachycardia, greater than 100 per minute. Idioventricular rhythm rate is 20 to 40 per minute. Accelerated idioventricular rhythm rate is greater than 40 and up to 100 per minute. Ventricular tachycardia, greater than 100 per minute. Mechanisms. Accelerated junctional and ventricular rhythms and most non-paroxysmal junctional tachycardias are thought to be precipitated by enhanced automaticity, due to enhanced phase 4 depolarization. Triggered activity initiated by after depolarizations, may also originate in the AV junction. Premature junctional beats. These beats occur much less frequently than premature atrial or ventricular beats. The timing of P waves and QRS complexes is variable, depending on the timing of atrial and ventricular depolarizations. P wave may precede the QRS complex, or may be absent, because it is concealed within the QRS complex or did not conduct to the atria, or may appear in the ST segment following the QRS. ECG in premature junctional beats. P wave direction, when present, is reversed, inverted in lead 2 and upright in AVR. QRS complexes are narrow when intraventricular conduction is normal. When P waves precede the QRS complexes, distinction from premature atrial beats originating from the lower parts of either atrium may be difficult. When aberrant intraventricular conduction is present and the P wave is within or after the QRS complex, distinction from premature ventricular contractions may be impossible without intracardiac recordings. Junctional rhythm. In junctional rhythm, the impulse arises in AV junction, at 40 to 60 beats per minute, depolarizes the ventricles, and may or may not conduct to the atria. If there is no conduction to the atria, AV dissociation will occur with the atrial rate slower than the ventricular rate, to the contrary of complete AV block, in which the atrial rate is faster. If atrial capture occurs, the P waves will appear, with reversed direction, just before or just after the QRS complexes or may be concealed within the QRS complexes. Accelerated junctional rhythm. The typical ECG pattern reveals slowing of sinus rhythm, with prolongation of PP intervals, and shortening of PR intervals, leading to the appearance of accelerated junctional rhythm. After a usually brief period, the PP interval begins to shorten, P waves reappear in front of the QRS complexes, and finally sinus rhythm reappears, and ventricular capture by the sinus rhythm is re-established. During accelerated junctional rhythm, slight changes in conduction patterns occur, and the QRS complexes commonly have slightly altered vectors, durations, and morphology, as well as minor changes in the T-wave vectors. Etiology of accelerated junctional rhythm. Acute myocardial infarction, particularly inferior. Digitalis toxicity. Acute rheumatic fever. Valve surgery. DC cardioversion. Cardiac catheterization. Chronic obstructive pulmonary disease. Electrolyte imbalance. Thank you.